Everybody see
Okay.
it?
All right. Well, welcome to the May 22nd, 2023 N3C Community Forum. So we're over 3 years, although we didn't actually start calling it Community Forum for a while. And so this will be recorded, and as usual, question and answer button and chat are ways to interact, and we usually get a lot of good discussion. Next slide. So yes, we're up to 7.5 million COVID positive cases. It's been growing more slowly. I guess COVID's been growing more slowly, or be actually interesting. Well, anyway, it's I don't know if anybody's actually looked at the rate of accrual of new COVID positive patients as a function of time in over the last year, but that's neither here nor there. Okay, next slide. So June 12th, Kate Bradwell will talk about protocol pad, and Saad Lajewski, apologize for the mispronounced name. I'm sure PPRL updates in the N3C Enclave, and there's been huge progress there, as people know. So this involves patient deduplication and new CMS claims data sets. So that should be very valuable. Next slide. So I think this is now our presentation. So we're going to hear all about oral health care and impact of COVID-19. And so that will be interesting to see if Yilin, Chen Liang think that there's found an actual potential impact of COVID on oral health, or whether this relates to changes in seeing dentists, which I'm sure it did lead to. Anyway, so I'm looking forward to that. And then Kate Bradwell will talk about transition to an Enclave-based publication 10 form, which seems pretty descriptive. So we'll hear details about that. Okay. So you guys can share your slides.
Okay. Can you guys see my slides?
Mm-hmm.
Okay. Good afternoon, everyone. Thank you for making your time to join this forum. My name is Ye. I'm the lead of the oral health clinical domain team. So our topic today is towards examining the impact of COVID-19 on oral health care. Since it's our first time presenting, I will briefly introduce our team. So I'm currently an orthodontic resident at SUNY Buffalo. Besides general dentistry and orthodontics, I also have my background in biostatistics. I'm passionate about using electronic health data to improve clinical outcomes and clinical decisions. And I also have Dr. Liang here with me. Dr. Liang is the co-lead of this domain team. He is currently an assistant professor at University of South Carolina. He has his expertise in EHR data and machine learning, and it's our pleasure to share our research questions and some of the current progress as a team to you guys. For this domain team, our meeting time is every second Friday of the month at 3:30 Eastern Time. So just disclosures that we have no relevant financial or non-financial relationships to disclose. So here is the outlines for our presentation today. I will go over the role of COVID-19 and long COVID in oral health care. Along with that, I will also go into some details of the emerging research questions. And from there, Dr. Liang will share some of the ongoing work at oral health domain team by introducing EHR phenotyping algorithm design and evaluation. And he will also talk about building EHR cohorts for observational study. And we will also discuss some challenges that we have encountered and our future plans. So on March 2020, the World Health Organization declared the global spread of COVID-19 epidemic. Until today, COVID-19 remains as a huge public health concern. Besides the typical symptoms that the patient may have, oral health conditions are very common in participants with COVID-19 during the pandemic. However, it's not yet very clear to what extent the outcomes are attributed by interrupted access during the pandemic, pathophysiological complications caused by the virus inflammation, or combined. So we have outlined 4 different aspects that we would like to assess the associations between oral health conditions and COVID-19 related outcomes. And they are interrupted access to routine oral health care, deterioration of periodontal condition due to systemic inflammation, possible inflammatory bone loss, and increased risk of dry mouth and oral lesion. So during the initial COVID lockdown, patients with symptoms of COVID-19 are advised to follow the CDC guideline, which is to avoid non-emergent dental care, because as we know that a lot of dental procedure, they're aerosol generated. So from this figure, it's from a study that was done in England from January 2019 to October 2020. By age group, it's a figure generated by assessing general dental services, and they categorize different age group and months. And from the figure, we can see the drastic decline in dental services used by all age group during the initial lockdown period. However, even the dental services visits are still much lower than before the pandemic, after resumption of the dental care. So role of healthcare interruption in oral health outcomes and health disparities is not systemically evaluated, and the reasons behind it are not very well understood. So with N3C data, we will be able to address these questions. Our next aspect that we are interested in looking into is the deterioration of periodontal condition due to systemic inflammation. So the figure on the lower right side of the slides is a comparison between a normal tooth versus a tooth with periodontal disease. Periodontal disease is mainly caused by infections and inflammation of the gums and bone that surround and support the tooth. So patients with COVID-19 may develop exacerbated inflammatory response, and this will cause increase in inflammatory biomarkers, and eventually that will lead to deterioration of the periodontal disease. And worsening of the periodontal disease might be very severe, cause the tooth loss and other inflammations. So, however, the periodontal disease itself is not that straightforward. It's very complicated. It's a disease that has many different risk factors, like showing in this picture. For example, patient's diet, psychological factors, genetics, and social determinants. So the role of COVID-19 in periodontal disease and the causal pathway are still not very clear. And we're hoping with N3C data, we will be able to address the co-founders and better understand the relationship between COVID-19 and periodontal disease. The third outcome that we would like to focus on is possible inflammatory bone loss. As we mentioned earlier, that the severe COVID-19 patient may develop systemic inflammation, and it will cause increased pro-inflammatory cytokines and chemokines. And those are usually highly regulated by our metabolic systems. However, when the infection happens, it will tip the balance off and disturb our normal bone metabolism. and it will eventually cause root resorption or tooth mobility. A recent in vivo study shows that COVID-19 causes significant loss in bone trabeculate in golden Syrian hamster model. And for COVID-19 patients, the best way to evaluate bone loss will be through the imaging data. And this is where the N3C data will be very helpful to us, because it will not only provide the electronic health record, it will also give us a chance to look at the imaging diagnostic results. And we will be able to combine those two to illustrate the relationship between COVID and possible inflammatory bone loss. And as oral health providers, routine X-ray may also help us to evaluate the condition of long COVID patients. For ortho patients, if the patient is currently suffering from active inflammatory bone loss, we will have to cease the treatment by stop putting any active force on those teeth, because at that stage, any extra force may worsen the bone loss and the patient's teeth may not be salvageable. So by focusing on this outcome, we will be able to give better guideline for clinicians when they need to make a decision. So the last outcome that we're currently focused on is increased risk of dry mouth and oral lesions. Oral manifestations are commonly found in COVID-19 patients. A recent cohort study shows that dry mouth and oral lesions were the most common oral manifestations in COVID-19 patients, with 44.2% and 22.4% respectively. Patients who received periodontal treatment before the infection reported fewer oral complaints and manifestations than those who did not receive periodontal therapy. And I personally found it very interesting, because we were wondering if providing more frequent dental cleaning or periodontal treatment might be more beneficial for those COVID-19 patients. And that will, the N3C data will be able to help us to find that out. And this is a brief summary slide that outlined our current interest in assessing the association between oral health conditions and COVID-19 related outcomes. So we're hoping with the help of the N3C data with evidence-based approach that we can improve the clinical outcomes and hopefully enhance the clinical decisions. And with that being said, I'm going to have Dr. Liang to talk a little bit about the progress update of our oral health domain team.
Great. This is Chen here. Thanks for you, Dr. Lin, for the wonderful introduction for the background and our major objectives for the domain team. So I'll take it over from here. So I'm going to briefly provide some of the research progress and updates for our domain team. So currently we are at a very initial stage on establishing the EHR phenotyping algorithm specialized for oral conditions and outcomes and several patient cohorts that we are interested in. And we are also trying to perform a systemic evaluation for the phenotyping algorithm that we have been developing. And then we are with develop a phenotype and a very well tested phenotype algorithms. We anticipate that we should be able to build some of the initial EHR cohorts very soon. So then after that, we should be able to start performing statistical modeling and machine learning training and evaluation. So one of the reasons that we need to prioritize the phenotyping algorithm development and also evaluation is because presently we know that phenotyping is the very first step for any EHR-based data mining and data analysis. So this is very important. So I will provide some of the basic concepts and the rationales in the next slide soon. So, and also, because for the oral health conditions and many oral patients with oral treatment, we currently do not see any existing phenotyping algorithms or any existing approaches that are published that can be used for our reference. So that's why, as one of the missions for the oral health domain team, we are going to start from the scratch and develop from the beginning to support many underlying downstream analysis and data mining tasks. So the reason that we are using the OMOP-based CDM to develop EHR phenotyping is because the entire N3C EHR data on N3C are normalized based on top of the OMOP common data model. So listed on the right-hand side, this is a figure and the architecture for the OMOP CDM. So essentially, with this OMOP CDM, N3C is able to normalize and integrate the different EHR format with different EHR vendors, different data formats, and different data structures from the different healthcare system over the country. So moving on to the next slide. So one of the reasons, so let me try to give a definition, a brief definition for the EHR phenotyping. So the reason that we need to use EHR phenotyping is because we need to identify the individuals with specialized characteristics and traits from the EHR data. But by using the medical nomenclature alone, or AKA medical terminology systems alone, may not be sufficient. One of the reasons is that patients with some of the information, majority of the information could be captured by billing codes, ICD codes, and procedure codes, and LOINC codes. But some of the other information might be buried in the clinical notes or in the laboratory results, from which you can perhaps see some of the inconsistency and ambiguity and a lot of missing information. So that's one of the reasons we cannot use medical nomenclature alone to capture the patient cohorts. We have to adopt EHR phenotyping. So what is showing on the left-hand side is a picture that Dr. Josh Danny that has presented and used for the NIH workshop a few years ago. So basically what we are trying to, the information what we are trying to deliver from this picture is that we are trying to deliver that by using the billing codes, medication coding system, or NLP with clinical notes and laboratory testing results generated from NLP alone. All of these methods cannot be sufficient to describe the accurate patient cohorts. So we have to combine all of these methods together to complete and design a comprehensive phenotyping algorithm. So on the right-hand side, this is a picture that we are trying to generate with some of the counts, but because of the HIPAA regulation, we are not able to present patient numbers and count and frequency on this figure. So we are trying to tap in the data from several OMOP domain and OMOP tables to try our best to capture the patients who have had oral health visits. So we are using the OMOP condition table and OMOP measurements table and OMOP procedure table and OMOP drug table to try to retrieve the data and try to figure out where we can capture the patients with oral health visits. So a little bit interpretation on this figure is that for the condition table, this is a terminology only used for the OMOP CDM system. Condition refers to where we can find a diagnosis and symptoms and achieve complaints for the patient during the patient visits. And the measurement is the OMOP measurement table referring from which we can find laboratory testing orders, clinical order sets, and many clinical orders. And the procedure OMOP procedure table is a table that captures clinical procedures, which is overlapping with clinical orders that are specialized for laboratory orders. And for the drug table, this is an OMOP table that has all the medication prescriptions, but we do not have any dispense data for that. So moving on to the next slide. This is our tailored and customized EHR phenotyping strategy that we are using. So basically, I will try to summarize our strategy into two different sub-approaches. One is called what we call the top-down approach, and the other approach is what we call the bottom-up approach. So these terminologies are originally borrowed from engineering domain that we used quite often for the biomedical ontology engineering. So here, the top-down approach refers to approach that we try to capture the patient's data by existing ICD coding system, CPT coding system, ARCS norm, and many other law encoding systems. So these are providing us from very generic and very broad approach to look into, to try to capture the patient data. And the other approach, bottom-down approach, this is the approach that we leverage some of the pre-identified semantic relationships, entity and relationships that we try to extract from the bottom of those OMOP concepts IDs that we identified. So with those strategies, we basically categorize our approach, our procedure into three major tasks. The first task is that we use the Athena vocabulary system to capture some of the OMOP concept IDs, from which we move on to the step 2, which is to look at some of the associations based on semantic entity and the semantic relationships. So from here, you can see that as long as we can identify any OMOP concept ID of interest, we should be able to figure out all the neighboring and the surrounding semantic relationships and those where those and all the conceptual entities and semantics that are related to that target based on the semantic relationships being defined. And then eventually we combine the results from the step 1 and the step 2, and it's going to be a repetitive procedure. Sometimes we need to go back and make some alignment to figure things out. So this work is basically done by primarily by myself and Dr. Lin and one of my doctoral students. So on the figure number 3, this is the very preliminary result for our phenotyping outcomes. So I have already masked some of the sensitive information from here, but what we are trying to generate here is basically try to capture a set of the OMOP concept IDs that can help us to capture any patients as long as they have any oral health clinical visits. So we are trying to move towards that direction. So moving on to the next slide. So with those preliminary EHR phenotyping algorithm development, we are missing several critical steps, which we will be doing for the next. So what we're going to do next is that we're going to finalize EHR phenotyping algorithm, and we are going to finalize and clean out all of the identified OMOP concept IDs. And with that, we are going to perform systematic clinical evaluation to perform internal validation, external validation, and cross-validation to make sure that the concept IDs that we generated and the algorithm that we generated are very well proved by clinical experts and also for the biomedical informatics researchers. So this is our next step. And with that, moving forward, we are going to elaborate on, based on our previous slides, please. Sorry. So we are going to build on our existing knowledge and experience to perform statistical analysis from which we should be able to implement outcome variables and covariates and many other covariates to perform the statistical analysis. And from there, we will develop machine learning models, which I have already had some of the projects and publications with some other N3C domain teams. We can borrow some of the wisdoms from there. And the next slide. So some of the, just a brief summary of some of the challenges Dr. Lin and myself and our team member have already encountered. So one of the challenges we have had is missing and incomplete imaging results. This may not be very severe for some of the other medical research questions, but we believe that this is a very important limitation for oral health. One of the examples would be that for the oral health patient, physicians oftentimes will need to use CBCT and many other imaging techniques to screen the patients to identify possible bone loss, many other periodontal conditions. But in the real world EHR, sometimes we can see that a patient is only captured because they have a diagnosis or chief complaint or any observed symptoms from clinical notes. But from a clinical point of view, this information may not be sufficient because in the real world clinical practice, dentists will need to evaluate the medical imaging, particularly the medical imaging results, combined with many other clinical observations, so they can make solid diagnostics to say whether a patient is really having a severe bone loss or not. And currently, this information has a great number of the missing values from the EHR data in the real world, also including N3C data. So this is what we have found from our preliminary study. And the second limitation that we have seen here is a missing observation. So we believe that missing observation is particularly a problem for oral health care. So I will give you one example. So what we have found is that during the clinical practice, many patients after the debound, for example, if they have a dental treatment and by the end point of the treatment would be a debound step. After the debound, before the debound, I would say, before the debound, some of patients may not be found, have not been found to have any bone loss or any oral complications. And some of the oral complication and disease will not occur before the debound. And typically they will occur after the debound. And this is very difficult, very challenging to capture if that happened, any complications happen after the debound. The reason is because after the debound, patients will not continue to see the dentist anymore. They will be transferred to the family doctor, where we can see that there's a huge, very large chance that any oral complication may not be captured by the family doctor or many other medical specialists. And this is also a severe problem for the long COVID conditions. So these are the two major limitations that we have found. So now from here, I will turn it over to Dr. Lin to discuss our future steps.
So as a team that our future plans include some of the priorities and future collaborations. So for our priorities includes identifying emerging research questions and vulnerable population in oral health, peri-pandemic and during the post-pandemic recovery. Oral health patients are very special, like it's even more challenging for the underserved community to get their routine dental care and special treatment. Developing electronic EHR phenotyping algorithms specific for oral diseases, examining epidemiology for ortho complications relating to COVID-19, examining the impact of COVID-19 on oral diseases and risk factors. So many oral diseases, like the periodontal disease, it has many different risk factors. So it's very important to examine the impact of COVID-19 and differentiate the co-founders. Identifying clinical evidence for better treatments. We are looking forward for collaborations. Clinician scientists in oral health, experienced data scientists specialized in medical informatics, EHR data mining, biostatistics, machine learning for health sciences. It's our pleasure to have the opportunity to share some progress and insight of this domain team. We're very excited to join this open science community. By collaborating with all the great clinician researchers and data scientists, our goal is to overcome technical and regulatory barriers and eventually reduce the immediate and long-term effect of COVID-19 as a team. Special thanks to all the institutions and researchers involved.
that's just what I think is realistic. So
Thank you for your attention, and any questions will be welcome.
Well, thanks. Great presentation. Any questions? So I have some questions. So it's obviously a big challenge to get information on oral care from something like N3C, which is obviously from healthcare systems. So maybe you could talk to us a little bit about what level of integration there is of dental information, and whether the images you're talking about are specifically dental images, or are you able to actually use other radiology images to estimate bone loss?
So typically for bone loss patients, it's going to be through the dental imagings. Technically, CBCT would be the best one to obtain, but a lot of time the general dentists, they take PA, it's like the localized X-ray on certain area to evaluate the bone loss. But usually, I believe in the electronic health records, as an oral health provider, we are required to write down the diagnosis, and I believe there should be the CBT code along with it. And a lot of time, if the bone loss is severe enough, we will refer the patient to get further evaluation. That will lead us to some radiology diagnostic results that we can extract from the data.
Mm-hmm. Are you using or contemplating using privacy preserving record linkage, PPRL, to link dental records with healthcare system records?
I can add a little bit of comment on top of this. So one of the issues, there are several issues. One of the issues is that many of the dental practice, they are private practice. So you can imagine that there is a broken linkage between the EHR system from the private practice to the large healthcare system. So which means that if we can trace down a patient with under the other radar, it's very easy. We can trace down all the clinical data from the system, hospital system, but it's very difficult to capture any data or comprehensive data from the private practice. So this is one of the interoperability and information system problem. So the other problem I would imagine is that, so when we look at the almost normalized data, we typically do not acquire the real medical image, which we only get all the radiologist's conclusion or radiologist's notes, which would be summarized mostly at the measurement, almost measurement domain. So this domain can give us some of the data, but I believe that there are a lot of missing values that are not captured there. So that being said, that these are the two major problems that we have identified for these imaging data linkage.
Great. So following up actually on this, David Sonner asked a somewhat similar question, but a different angle. He says, thank you for the talks. Yeeland's slide suggested the decisions to skip routine oral health care and or COVID-19 related inflammation might be responsible for deterioration of oral health. Right. Question one, roughly what proportion of patients do you think receive their oral care through N3C participating institutions as opposed to independent dental practices? We'll start out with that.
So I will take the second question first. For the second question, so based on our very rough observation, we think that the majority of the patients we can capture are those from the dental clinic at dental school. So they have the student dental clinic where you can see that many patients are admitted to those kind of clinics. So we see a lot of patients are from a large clinic associated with the dental school, but we do not see a lot of patients from the private practice, or we don't see a comprehensive data for longitudinal records for those patients. For the first question, I don't have a clear answer to that. I think that might be a cross-domain team discussion that we can brainstorm some of the ideas. So currently, I don't have a very effective way to address that issues.
So, and then actually another question of David's is, of those followed at participating institutions with COVID-19, approximately how many have inflammatory biomarker data over time? CRP, sed rate, plasma viscosity, and or cytokine levels.
So I will turn it over to Dr. Lin because she provides me with a list of the interesting biomarkers that we are trying to capture. So we can, from my end, I can take this answer to the question that we are able to find some of the biomarkers. But the question mark that we have is that we are not sure if those biomarkers that we captured are comprehensive. And also Dr. Lin can help with some of the clinical insights on at what occasions and frequency in what scenarios that dentists will send the patient to do the laboratory test. So this is also very critical. So Dr. Lin, do you want to take it over?
Yeah, so first of all, I want to add something to the first question that, during the pandemic time, a lot of patients actually are seeking dental services, but compared to the private dental practice, the school actually are the ones that seeing the most patients and have all the data because of the PPE issue. They have all their personal protective equipment and they have all their equipments to protect the providers. So like what Dr. Liang mentioned earlier, I think a lot of patients that we will be able to extract data will be from the school institution. And for the second question, the main aspect we're focusing on, especially for the inflammatory bone loss, will be with severe COVID-19 patients, which means that those patients are probably at some point hospitalized. And when those patients got hospitalized, their primary provider will refer them to do the blood panel. And in the blood panel, a lot of time they will include those inflammatory biomarkers because they're very critical to know as their primary providers. For now, we're mainly focused on the interleukin-1, interleukin-6, but we're at the very initial phases to understand the relationship between certain cytokine and the biomarkers and with the oral conditions.
Wonderful. Well, I want to thank both of you. I think we should probably move on to Kate, but a great presentation, a lot of interesting discussion. So, and we're all looking forward to seeing what you guys find.
Thank you.
Thanks. So Kate, do you want to share your slides?
Thanks, Jill. Actually going to share my screen. Okay, so as you all know, the publication committee exists in N3C to ensure that correct procedures are followed. And this was the link to the previous publication intent form here, CD2H website, publication review. So basically the job of the publication intent form is to ensure that patients and data partners are protected within the publications, and that the publication committee can ensure that data is collected on presentations for conferences and for journal submissions such as manuscripts is collected, and all the appropriate declarations, acknowledgements that pertain to the rules and regulations of N3C are followed. So this was the previous N3C publication intent Google form. And the issue the publication intent had previously was it was very difficult to collect all the metadata about publication and kind of download requests and concept sets, knowledge store items that need to be linked to the publication intent itself to be able to verify that the content in the publication is indeed what was approved by the download request. And as we all should know by now, that's extremely important because we're dealing with patient data and we need to protect the patients and data partners that are submitting the data to N3C. So in order to better track the download requests and other metadata that's associated with publication intents and publication intent submissions, we now have moved this process to the Enclave itself. So you'll now see on the N3C homepage, we have a link to the publication intent form. Just have to move this publication intent form is now linked here. So you can see you can create a new publication intent. So demo for, you see, community forum. So this enables you to begin your publication intent within the Enclave. So you see a link at the beginning, you link to the download requests of your publication. And this download request then populates this form. And you say, yes, my work has patient data or involves patient data and data partner information. You also fill in how the work fits with the data use request. You select authors. So, for example, whoever the authors are. And then you go through the process of adding your declarations. So you, for example, declare that you have looked into sources of data heterogeneity, and DUI ID has been included in the paper, etc. Save and continue. This is where you can link further metadata aside from just a download request, so you can acknowledge domain teams that helped with the work. Individual contributors. So say, researchers, so say Julie was involved, Julie McMurray. Concept sets, so you're linking concept sets via just a list of IDs, and they can be either comma separated or new line separated. So say you've used these 3 concept set IDs. You can easily obtain these if you say have a table of the concept set IDs you use for your work. You can just copy and paste the column of concept set IDs here. Knowledge store items. And then further verifications. So say this is a journal manuscript and you want to submit to JAMIA, you would put, say, the date. And then any comments you want to provide to the publication committee. And then you just review all your entries, so everything that you've entered is correct. Review all the linked metadata as well, the domain teams, the knowledge store items, the download requests, linked concept sets, linked individual contributors. I'm not going to actually submit the form because this does actually send an email to the publication committee and a copy to authors as well. So once that's submitted, the emails get sent out to the publication committee, to the authors, with all the details of the download request as well. So the description of the download request ID, and they have an actual link to the contents of the download request so they can view a lot easier than they could previously. So they can verify, is the content of the download request correlating with the content of the manuscript itself. After the publication committee receives that, I won't show you their dashboard because that's private to the publication committee, but they look through the submission, they look through, verify, cross-check the download requests and link metadata to the submission. And then they suggest edits to certain fields and say, this is, let's do this. Let's see if the demo is there. I haven't submitted that yet, so say this one. So you have your submission, say it's for this research project and it's this submission, this manuscript ID. You would see the consolidated revisions comments from the publication committee here once they've made their comments, and you would see their required fields for revisions. So that could be things that they find important, such as if you need to include extra download requests, if you need to include edit to explanation of how the work is within the scope of the DUR. If, say, you need to revise some aspect of the manuscript title, that will be detailed here as different fields. And then those fields that they specify will become required fields in this submission. So you go and edit all the information, and then you submit, you detail what the changes were, and then you submit, and that submits the revisions. So the publication committee will then look at the revisions. They'll say, okay, this is now addressing all of our concerns. And then they will optionally send another email from their dashboard, the publication committee dashboard, with further revisions that are required, or they will send an acceptance email from their dashboard saying, we've now accepted this submission, this publication intent submission, please go on to submit to your journal, target journal, etc. So one thing I'd like to point out also is that from the initial publication intent form and from the revisions form, we're including this publication utilities link. So that actually links to this publication utilities dashboard, where you have useful links to the initial submission form itself, which you just saw, to the revisions form, which I just showed, the guide to the publication intent submissions using those two interfaces, and also a guide to download requests and how to download download results outside the enclave, the instructions here. Also several useful links. So the N3C acknowledgement text, when you click on that, it'll open the acknowledgement text. The scholarly output, so a link to all the scholarly output from N3C. Publication committee video. So the video from N3C. So let's see. If we go to this part of the video, Swari is explaining what types of material needs to be submitted to the publication committee. So all manuscript drafts, all conference submissions, poster, podium presentations, and posters. So we need to the publication committee need to receive submissions in the event that you have manuscript drafts or podium presentations or posters for conferences. Also, in this dashboard, there's going to be a set of tools. For now, we've got a concept set table generator. So you can actually generate a supplementary table for your journal submissions, listing all the concept sets that you use and metadata about them to provide attribution of who actually created them and some details of the concept sets themselves. So does anyone have any questions about the process as a whole?
Wow, that's impressive. You really automated this.
Everything's automated, yeah, and everything's tracked.
That's nice because it's really hard to sort of remember what went where.
Yeah,
That's fantastic.
yeah, and definitely it enables a more seamless back and forth between the publication committee and the authors, where everything is tracked for the publication intent submission itself.
Right. No, that's great. And people don't have to remember all of the manual steps and such. So that's wonderful. Okay. Other comments, questions? I'm not an expert in the publication committee, but I've been a fellow traveler in that. So I've sort of watched it develop. So that's great.
Joel, there's a question in the question and answer.
Okay. Hello. Ideally, how long before publication should we fill these out? From Myrna Elizondo.
Oh, sorry, I just saw the first question, the direct link to the publication intent form. That link just doesn't work for me, but for researchers it will work, sorry. I'm on a different kind of track view of the form. So the second question, ideally, how long before publication should we fill these out? So as soon as you've completed work for a manuscript, you would submit to the publication committee. I don't know if any members of the publication committee are on as well, that they want to add extra details to that. I think the publication committee aimed to review manuscripts for journal submissions within 5 days or a week.
Great. Awesome. Thank you, Myrna says. Jiang said, I think I figured that out.
Yeah, everyone can directly click on the link from the homepage. Sorry about that. It's just I couldn't because I had switched it to a different mode.
Cool. All right. Well, this is impressive work. Very great description. Okay, I want to thank everybody, and we'll see folks in a couple of weeks. Take care. Bye-bye.